terms of what we've been able to discuss so far. We've had, next slide, we've had two previous meetings in the past. The first meeting was in March 17 and 18. We had 2 days because it was a very long and comprehensive meeting. And that particular meeting, just go back to the previous slide. In that particular meeting, we provided updates from research partners and technical partners on the activities related to hepatitis B birth dose vaccine in Africa. We had CDC, WHO, the coalition, who provided an update, the latest update on the introduction of hepatitis B birth dose vaccine and the status of birth dose programs globally and regionally, and the current priority research and technical assistance activities. Research partners and also technical partners also provided updates on their current and upcoming projects related to the hepatitis B birth dose. The second meeting was held on May 5th. And this particular meeting, we invited several Ministry of Health officials, including hepatitis B focal persons, as well as API officers. And these particular meetings, we wanted to learn as we build this community of practice from these officers who have been working on the ground on hepatitis B vaccine to share their experiences related to that whole process. Countries that have already introduced the vaccine and those ones who are in the process of introducing the vaccines were able to participate and give us quite a very detailed picture of the whole process and their experiences in implementing the hepatitis B birth dose vaccine. We had countries such as Botswana, Ethiopia, Ghana, Mali, Mozambique, and Nigeria and South Africa present during this meeting. Next slide, please. We had so far we've had about 24 countries represented by various participants. About 220 so far have registered and actively participated in this meeting. These participants have represented various organizations, including ministries of health as well as NITAG representatives. We've had WHO staff. We had technical and implementing partners participate, research partners, international funding agencies were also represented, as well as civil society members and others who were also welcomed from other aspects of professional affiliations. Next slide, please. If you missed the first two meetings, you're not all lost. These meetings have been recorded and they are available, plus reports, very detailed reports highlighting the key points from these particular meetings. And they're available at www.globalhep.org. This can be accessed through the internet and you can be able to get all these materials. Next slide, please. So I'll give you a brief picture of what we have learned so far from the meetings that you've had in the past. We know that there are more than 60 million. In fact, this number has been updated, and this you're going to learn later on in this presentation. We have more than 60 million people currently living with chronic hepatitis B in Africa, and the prevalence is more than 6%. Which is very high compared to the rest of the world. Africa ranks second with that high prevalence. Hepatitis B virus infection during infancy confers the highest risk of chronic infection, and this predisposes them to suffer quite a number of complications, including liver cirrhosis, as well as hepatocellular carcinoma later in their lifetime. Unfortunately for Africa, despite the fact that there has been a vaccine that has been able to prevent, only 14 countries have been able to introduce the hepatitis B birth dose vaccine, which is very important in preventing mother-to-child transmission, which again, as I said, infection at that early stage results in the complications that I didn't mention. Africa has not been able to meet the 2020 interim goals. Currently, the whole world, we have had a prevalence of less than 1% hepatitis B surface antigen among children less than 5 years of age. And in the African region, we stand at 2.53%. Next slide. So some of the key takeaways from the previous meeting is that Africa faces quite a number of barriers towards the introduction as well as the administration of a timely hepatitis B birth vaccine. And some of these barriers include poor coordination between the expanded program on immunization, as well as the maternal child health programs. And as well as there's a lot of home deliveries that make access to mothers who deliver and to babies who are born and need the vaccine not be accessed. There is a need for awareness among policymakers on hepatitis B vaccine importance in eliminating mother-to-child transmission. And they also need to be aware that this is really a cost-effective strategy so that they are able to support it. There is need to build advocacy, to build local support amongst healthcare workers, to understand the importance of this vaccine, to understand why it should be given timely, and also to create advocacy amongst mothers when they're pregnant so that they can be able to demand the vaccine once they deliver their newborns. There's also need for funding, and we are happy that Gavi is in the process of trying to see how best they can be able to provide support for the introduction and scale up of this vaccine. Next slide. In today's meeting, like John mentioned, we are going to continue building this community of practice. And thank you so much for coming, because this is not our own effort. It's really a community approach. And we want to learn from you and also get the best practices from you so that we can be able to work together to making sure that we are able to achieve this strategy. We want to identify NITAG needs from countries that wish to introduce the hepatitis B birth dose vaccine. And also we'll be presenting a draft toolkit, like I did mention, on resources that can be used to support NITAGs in the evidence generation in support of hepatitis B vaccination recommendations. And we really would like you to give us as much feedback as possible on how best we can be able to improve on these resources. Next slide, please.